All right. 35-year-old woman comes to the office due to solid food dysphagia for the past several months. All right, guys. Dysphagia. We'll break down dysphagia. Let's read this question. I'll tell you all the little tricks about dysphagia. There's some tricks that's supposed to create a specific type of bias in your head when it comes to diagnosis. Biases are good, guys. It's good to have some kind of diagnosis, preliminary diagnosis in your mind while you're trying to decipher like what the answer is. Now, I'll tell you my strategy. I look at this right here, the answer choice. A lot of people would say, cover the answer choice, don't look at it. I'm not one of those people. I use the answer choices to let me know what ballpark we're in. So I don't go through it thoroughly or anything like that. I just scan my eyes on it and I say, okay, this looks like a cardio question, just looking at the answer choices. Then I read the bottom line, it says enlargement of which of the following is most likely causing this patient's dysphagia. Right away, I think I already know the answer. You see what I mean? That right there is like a bias that you create in your head. Now you read the question. What am I expecting? I'm expecting either to rule it in or rule it out. And if you guys did not know, it's okay. Yeah, definitely. If you guys did not know, it's okay. But something in the question should help me rule in or rule out. So 35-year-old woman comes into the office due to solid food dysphagia for the past several months. The patient has a sensation of food getting stuck in the mid thorax, all right, but has no pain or reflux. Okay. She also has palpitations and dyspnea on exertion. Okay, that's another clue. The patient immigrated to the United States from India a year ago. Oh my God, they're giving so many clues here. Yes, mitral stenosis. Yes, maybe this patient might have had some kind of rheumatic heart problem, right? Acute rheumatic fever leading to rheumatic heart disease. That's maybe what has happened to this patient, right? But let's see. And she was treated in her home country for rheumatic heart disease. Look at that. I didn't even read it, honestly. They're giving all the clues for this, guys. This is what we call a gift. But okay, barium esophagram demonstrates extrinsic compression of the mid esophagus. Enlargement of which of the following is most likely the cause of this patient's dysphagia? Guys, what is the answer? What do you guys think? And we'll discuss all the clues and all the things behind this. Bluina says A. Does everyone agree? Does everyone agree? A, 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 A. Makes sense, right? This is like a softball question here. Really softball question. Yes, definitely. So looking at this scenario, let's break this down. And I'm going to break it down to you guys with a couple of things because there's a couple of things that you do want to actually be aware of. One thing, first of all, the idea that the patient has solid food dysphagia. All right, and I'm not sure if you guys are aware, but dysphagia is a huge thing. Like this is something where you can guide yourself with. If the patient has, let's say, a dysphagia with odynophagia, basically pain when swallowing, rather than like a discomfort or dysregulation when swallowing, just pain, odynophagia included. What should I be thinking of? Do you guys know? What should be like the bias that comes into my mind specifically? Are you guys aware of that? Let me know. Type it in there. What do you think if it has dysphagia? Patient has dysphagia and odynophagia. It's okay to be wrong, guys. It's okay to be wrong. Okay, Judith says achalasia. All right, good. So your mind will go there. Lena says Candida. I'll tell you guys. You guys should automatically be thinking esophagitis. Esophagitis. Why esophagitis? Well, esophagitis is something that um, it's displaying a level of inflammation. And if there's inflammation, most likely there would be pain. There would be pain when swallowing. So all I'm telling you guys is formulate your mind to create certain types of bias. This is not only just learning the material, but you also have to learn how to think properly in order to go down the right path to get your answer. So if what I'm telling you right now is if you see a patient who has dysphagia plus, of course, I'm going to spell odynophagia wrong. Odynophagia. First thing you should be thinking is esophagitis. It might not be the answer at all. It might not be the answer, but you should keep reading the clinical vignette to either try to rule that in or rule it out. Okay. Now, there's different types of esophagitis. If I see that the patient has a history of, let's say, allergies, patient has, let's say, asthma, he has eczema, I might think that the patient has eosinophilic type of esophagitis. Okay, eosinophilic type. This is the different type. Let's say the patient has she's been taking medications. She's been taking certain types of medications. There's also a pill-induced, drug-induced esophagitis. That's another type. Yes, if she takes meds. Now, what kind of medications are those? I'll give you guys a mnemonic, really easy. 1, 2, 3, 4, 5. 1 is for iron, right? Iron tablets. Iron tablets. Patients who are taking iron tablets are those that, let's say, they have iron deficiency, anemia due to excessive bleeding, menstrual cycle problems, von Willebrand, let's say. Okay, 2 biphosphonates or bisphosphonates. That's 2. Bi for 2. 3 is 3 letters, potassium chloride. 4 is tetracycline. Tetracycline. Tetra is 4. And then 5 NSAIDs. Perfect. 5 letters. If you remove the S, 5 letters. But yeah, NSAIDs. All right, those are the drugs that would cause pill-induced esophagitis. Keep that in mind. It's a little nice mnemonic for you guys to remember that. So if I see that the patient is taking meds plus dysphagia and odynophagia, I'm thinking, okay, pill-induced, also called drug-induced esophagitis. Okay, if I see that the patient has allergic symptoms, like let's say he has asthma, eczema, like we mentioned before, history of that, pruritus, anything like that, then I'm saying it's eosinophilic esophagitis. Okay. Now let's continue. Now let's say the patient has HIV. Oh man. If the patient has HIV, it can be 3 different types. What 3 different types of organisms should I be aware of? HIV or immunoincompetent patient. Immunodeficiency. What 3 types? Herpes, CMV, Candida. Herpes, CMV, and Candida. So HSV1, CMV, Candida. Perfect. The description itself should let you know the answer, right? Because each of them have different types of description. Now I'll ask you guys, do you guys recall what is the specific description for a CMV type of esophagitis? Let's go. We're going to get a little more linear. Yeah, linear type of ulcer, definitely. What is the treatment for CMV? Do you guys remember? What is the treatment for CMV? Gangcyclovir. Good. Yes, Miriam. Herpes, punched out, definitely. And for Candida, if you look at Candida, for herpes, let me just tell you HSV. They say small, shallow, punched out ulcers, right? Vesicular. Anytime you see vesicular, always think herpes. But there's a couple of things that are vesicular that can also fool you, so watch out. And we'll talk about those things as well when we dive more into infectious disease. But yes, remember that CMV is large, linear. HSV is small, shallow. Candida has white plaques, cottage cheese type of appearance naturally, normally. So what's the treatment for Candida? Can you guys tell me what is the treatment for Candida? If you have Candida esophagitis, fluconazole is correct, and be careful because if it's oral thrush, it's not in the esophagus. If it's just oral thrush, you'll find that in the posterior, like the pharyngeal area. If that's the case, you use nystatin. If you have esophagitis because of Candida, you're using fluconazole. If you have vaginitis because of Candida, what are we using? You guys know? Vaginitis, you can use fluconazole. Not Itra. Not the Itra. This is clometrazole. Clometrazole is the one that I like to use. It's over the counter. I think it's Vagisil. that the clometrazole type of treatment. I'm just getting a little specific because I've been diving into step 2, step 3. So a lot of specific stuff is going to come out now. You guys are going to get a lot more specific type of medications and treatment. So definitely keep that in mind. But yes, 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 definitely. Yes. Yeah. So, but when you take an antibiotic, yeah, there's different risk factors. There's a whole bunch of different risk factors involved. Yes, that is true. There's also, I remember atrophic vaginitis, just the fact that the patient's estrogen gets lower at the moment of menopause, the surface area decreases, but the colony remains the same. So therefore, you get easier to get an infection. I don't know if that makes sense. Think about it. If I have a certain amount of bacteria or microorganisms occupying specific amount of tissue, if the tissue gets smaller, the same number of bacteria or microorganisms are still there, they're more prone to cause infection because of atrophic vaginitis. I don't know if you guys heard of that. Oh, let's see. But when you take antibiotic, then sent. Um, typically, when typically when it comes to itraconazole is used for a lot of different types of fungus, especially if fungus are trying to disseminate. I know that the dissemination of fungus definitely you'll have to use things like itraconazole. Itraconazole. Um, there's also amphotericin B. Yeah, we'll talk about that. That gets a little more extensive. I should ask you guys actually. Now that we mentioned so many drugs, one of my questions would be, what are the mechanisms of action? This is something that is highly tested. Just knowing the drug name is not enough anymore. They might not even put that in the answer choices. If they're trying to target a question that's based on treatment for a specific type of disease, nowadays they wouldn't even put the answer, they just put the mechanism of action. So what is the mechanism of action of the azoles, like fluconazole, for example? What does it actually inhibit? Do you guys know? If you know it, type it in there. 1,4-alpha demethylase inhibitor. Yes. Guys, try to remember fungal cells. Fungal cells have something called ergosterol. Ergosterol, right? So you have to consistently make your ergosterol, and you're supposed to display this ergosterol on the membrane. It's like a pore in order to let things come in and out, in order to create a level of permeability. So yes, you have squalene turning into squalene epoxide, turning into lenasterol. Then finally, you make your ergosterol. Ergosterol. So there's different drugs that will inhibit the production of ergosterol. So yeah, alpha 1,4 demethylase. It is an enzyme. It's an important enzyme. It's a P450 enzyme, guys. It is a P450 enzyme. It's an enzyme of the liver. We also have this in our liver. So if you are trying to target this type of enzyme, you'll also end up triggering an inhibition of the P450 system. And we see this more with other types of drugs like ketoconazole. Ketoconazole is one of the big types of drugs that inhibit the P450 system, right? Remember, if you inhibit the P450 system, the drug that the patients are on, it would linger for longer periods of time, right? Therefore, you would have massive effect. The therapeutic window, right? Certain drugs have therapeutic windows where being within this therapeutic windows just means that you're getting more benefit as opposed to side effects, as opposed to adverse effects. You're in the window where you are benefiting. If you cannot break down the drug properly, you cannot metabolize it correctly because of the liver, you will increase the amount of drug in the system, leading to you basically leaving the therapeutic window. So you're more prone to adverse effects. Does that make sense? Drugs like warfarin depend on the P450 system, guys. So if I give ketoconazole, here comes my question, guys. So pay attention here. Here comes the question. If I give ketoconazole to a patient who's on warfarin, does the INR increase or does it decrease? Will I have an increase in INR or a decrease in INR? Give it some thought. Increase in INR. Yes, good, good, because warfarin will linger for longer periods of time. Warfarin will be out there causing more and more effect, right? Good. You guys remember that, right? That's good. Remember, guys, that um, vitamin K, how does vitamin K affect the system? Because warfarin basically is inhibiting this system of the, the merits of what vitamin K can actually do. Do you remember the actual mechanism of how vitamin K um, increases the? Okay, you say extrinsic pathway. Well, be careful. Be careful. I'll tell you why. Epoxide reductase. Yes, gamma carboxylation of epoxide reductase. Gamma carboxylation of epoxide reductase. I know that you guys understand a lot of things when it comes to the coagulation and all that, but I'll tell you guys one thing. Yes, you might see the answer choice where it talks about gamma carboxylation, and you might not you understand that vitamin K contributes to higher production of clotting factors, but you don't really understand how, and that's a problem. So get all the information in there. So let me break it down for you real quick. There's gamma carboxylation of epoxide reductase. This allows you to make certain types of clotting factors and certain types of proteins. So it's not exclusively the extrinsic factor. It's both. It is both, but the extrinsic factor stands out the most, and I'll tell you why. Yes. Well, yeah. You have the whole mnemonic. 1972. Disco 1972. That's the mnemonic. Disco 1972. So what does that mean? Clotting factor 10, 9, 7, and 2. 2 is thrombus, remember that? And then protein S and protein C. Protein S and protein C. I don't know if you guys remember the function of protein S and protein C. Remember, they are to make a complex. You guys remember that? You are to form a complex. And this complex goes opposite direction of the procoagulant types of proteins. So understand, it is kind of weird because in one hand, we have clotting factors like 10, 9, 7, and 2 that are going to promote the clotting cascade. And then you have protein S and C, which will be basically stopping or inhibiting this cascade. So definitely keep that in mind. Keep that in mind. Yeah, they're anticoagulant basically. Yeah, they make a complex. They make a activated protein C complex, APC complex. But okay, really quick, let me just tell you guys before we lose the train of thought. Why is this? I mean, look at this. 10 is from the common cascade. 10, 5, and 2. That's the common cascade. 9 is from the intrinsic. 7 is from the extrinsic. 2 is from the common. So we're seeing that this is going to affect PT because of 7, right? Which is extrinsic. Remember, guys, extrinsic is PT. Extrinsic. And then you have intrinsic, which is the other side. Yeah, this has a whole bunch more. You have clotting factor 8, 12, all that. But I'm just saying, I'm just separating it by size. You have here the common pathway. So as you guys can see, 7 is found here on the extrinsic pathway. But the reason why people tell you that, oh, warfarin has to do with clotting factor 7, therefore it has a lot to do with the extrinsic pathway. In reality, it has to do with both, because of the half-life. Yes. So let me tell you what happens. If I start to decrease, and this is a good concept I'm going to give you guys, so pay attention here. I'm going to connect this to another concept. Think about this. If I am going to decrease these clotting factors, decrease 10, I start to decrease the production of 9, decrease the production of 7, decrease the production of 2. The one with the shortest half-life is the one that will show up in labs first. It'll show up in labs first. Therefore, they'll tell you that you can monitor warfarin adverse effect by looking at the PT. Does that make sense? But PT basically becomes irregular before the PTT does. But if you keep going down that route, you'll have a problem with both PT and PTT. Okay. So keep that in mind. That has to do with the half life. The one with the shorter half life is 7. That's why. So, what is the treatment of someone who's overdosing on warfarin, who has issues with the PT and not, let's say, it's also affecting the PTT? What do we do? Yes, fresh frozen plasma. Fresh frozen plasma. It's not vitamin K anymore. I'll tell you why. Vitamin K is more like for, let's say, a long term type of issue, just because it's going to be hard to get your liver to produce your factors, your clotting factors, at such a rate where it becomes corrective without having symptoms, without having any complications. So there's an issue in the corrective process where it's going to take too long. So fresh frozen plasma should be the answer for a patient who has an overdose of warfarin for sure, right? You guys remember that. Now there's so much other things in here. There's so many other things. I'm just going to tell you. You guys have to be aware of the timing. So the timing of things are very important. The timing. So right now we just gave you guys a good example of the timing when it comes to warfarin, and the clotting factors. Now, guys, really quick mnemonic. At war, I always remember I used to be at war with my ex. So war is the extrinsic. Extrinsic is what will become irregular, right? That's war. And then I remember HEP has 3 letters. HEP. I remember PTT. 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 That makes sense to me. That's good. So yeah, that's how I remember. Keep that in mind. But okay, let's continue. I'm going to give you guys now another little trick here that also has a lot to do with timing. And this is something really weird. Let's say a patient has a G6PD type of problem. So we're just talking about timing, the concept of timing. Let's say it's a complication with G6PD, right? She has G6PD deficiency. Let's say you gave her some kind of a Primaquine or something. You gave her Primaquine. Why? Because the patient was going to travel to like some country that has Vivax and Oval. You guys remember Vivax and Oval? Try to remember, guys, the timing of the fever is so important. That can just get you the diagnosis. Remember, malaria, this one has a 3-day interval of fever. You can tell because 1, 2, 3 dots here. You see that? 3-day interval. We're talking about malaria really fast. Vivax has 2. You can tell because the 2 little points. And then falciparum does whatever it wants. You can have fever all day, skip a day, doesn't matter. Does whatever it wants. All right, perfect. So we got this down really quick. Now let me just tell you guys, Vivax and Oval, they're like cousins. They're like cousins. In Spanish, we call that, we say primo, like primo. So for these type of patients, not only do you have to give, if they are chloroquine sensitive, give them the chloroquine, yes, but you also have to include Primaquine, because these type of malaria have the ability to go dormant. So remember, you have a mosquito here, really quick. Mosquito, let's say, bites you with his saliva. He gets some saliva into your system. I think sporozoites. Okay, the sporozoites are in the saliva. But once it enters the bloodstream, it enters to the liver and it becomes, I think, hepatic, I think, hypnozoites. Hypnozoites. Now, guys, just in case, I'm doing this without any notes, just going from the top of my head, just because mnemonics like this just stay in my head. And you have to learn how to like try to make this information your own by I'm giving you how my mind, how my brain more or less can work, but you can just use this as something to remember, because here hypnozoites are when they are dormant at the level of the liver, and then they move out. When they move out, it's merozoites. Merozoites. Of course, I'm spelling it wrong. Zoites. That's when they move out, right? And then they inoculate the RBCs and they become schizonts and all that. But okay, my point is this. Vivax and Oval can become hypnozoites. That's a problem. Therefore, you need to give medication just in case they're in a dormant state. And that's primaquine. But the problem is that patients with G6PD, patients who are prone to have G6PD exacerbations, can undergo an exacerbation if you give them things like primaquine. Wow. Okay, if that's the case, let's say they have G6PD. There's going to be a question, guys. There's going to be questions out there that'll tell you what's they'll throw a little wrench at the whole system. They'll tell you that the G6PD enzyme activity is normal. And you'll probably be thinking, what in the world, what in the hell is going on here? Like, I thought I had this question. I thought I understood everything, but they just told me right now G6PD enzyme activity is normal. What in the world is happening? Well, no, they'll tell you it's great. It's normal. The activity is working great. Everything is awesome. G6PD is a star, basically. All right, so what in the world is happening? I'll explain. Well, what happened is this. It's all about timing. Remember, we were just talking about timing and how timing does matter when it comes to a lot of labs. That's what a lot of people in step 2 are also learning at the moment, is that everything's not just like step 1, that, oh, this is high, so this is low, or no, it's all about timing. So take a look at this. What you have going on is that the cells that had the deficiency, let's say, of the G6PD, the ones that had the problem with G6PD, those cells are the first one to get lysed. Those are the first ones to undergo hemolysis. Remember, this is a pathway where you're able to create glutathione, which will protect your RBCs from free radical damage, right? From oxidative stress. So the ones that had the lowest amount of G6PD activity are the ones that died first. So when you're doing this panel, when you're doing this test on a patient who actually has active hemolytic anemia, it will look normal. It will say it's normal. The reaction will be good because the cells that are still alive at that moment are the ones that more or less have normal activity. You see what I'm saying? The ones that didn't have the normal activity died. It's all about timing, guys. A lot of this thing is all about timing, and they're going to try to test your logic when it comes to timing a lot of times. Everything is leaking over as well. I see concepts like this in step 1, same way I see it in step 2. It's just wild. Like, all these exams, step 1, 2, and 3 are looking the same to me now. Like, the more I get into it, the more questions I do based on this, the more I see this. Yes, I'll repeat it, definitely. So G6PD enzyme activity is actually measured. But what happens? At the moment that they're measuring this, the patient is coming into your emergency department due to an extensive amount of hemolysis. So much so that you'll see a normal cytic. So the MCV would be normal, let's say, MCV, because it's an acute type of hemolytic problem. So it's definitely causing an acute issue. Remember, you have Heinz bodies, you have all these different types of clues. Peripheral blood smear will give you as well that it's a G6PD problem. MCV will be normal. Reticulocytes will be high. Reticulocytes, let's say, would be increased. And then you get all the extra clues, like the haptoglobin is low. Remember, haptoglobin is that, think about it like something that binds to remnants of RBCs. If RBCs are getting lysed, haptoglobin is going to try to bind it. So in a hemolytic type of anemia, you'll notice that haptoglobin is low because it's bind to everything else. But what I'm telling you is this. If the patient has a legitimate type of G6PD deficiency and he is undergoing hemolysis at that moment, what a test writer can do to try to trick you is that they will say G6PD enzyme activity is normal. That they did a test on the patient and they found that it was normal. This might be the case in acute hemolytic type of anemias with G6PD. Why? It's because the cells, the RBCs, that had the very low activity of G6PD enzyme, they died. By the time the patient's in your office, those cells were not able to create the proper amount of glutathione in order to sustain oxidative type of reactions. So they were able to undergo free radical damage and get lysed and destroyed. So by the time the patient's in your lab, in your office, you're checking for G6PD enzyme activity, and it's normal because the ones that are there, the ones that survived, have more or less a normal activity. They're the ones that are still withstanding the problem. Yes, you will still see it because there has been havoc. There has been destruction of hemolysis. That's evidence of all the destroyed RBCs, the ones that did not have the proper amount, the proper level of G6PD. Remember that it's like on a spectrum. It's not a 0 or 100. Yeah, I've seen that used as a trick where in the question they'll tell you, they give you all this information of G6PD, and then they'll tell you that they did tests, they did diagnostic tests like G6PD enzyme activity, and it's normal. So when do you check this? You're supposed to check it 2 weeks after the hemolytic event. 2 weeks after the hemolytic event, you should have produced RBCs that are deficient in G6PD. The new RBCs are now coming back into the game. You know, they're coming back into the game with the same type of issue, same type of problem. And your patient is now back to his normal status of G6PD deficiency. So 2 weeks after the hemolytic event, then his RBC G6PD enzyme activity will reflect the deficiency. Okay, it will reflect the deficiency. This is where you can get an accurate reading. Okay, does that make sense, everyone? Does that make sense? Yes. Good, good, good. Yes, there's so many tricks like that, guys. I'm telling you, this exam is wild. You'll see more and more things coming up. So yeah, that's just one trick. So you guys do not fall for that. They love that trick. They love it. Okay, good. We talked all about warfarin. We were talking about odynophagia. We were talking about dysphagia. We went through a crazy ride right here. The answer here, yes, definitely is left atrium. It makes perfect sense. I mean, this one right here is good. Just note that dysphagia with odynophagia is definitely uh should be an esophagitis. It's something that you can guide yourself with. Okay, yes, Marianne, that's the problem. Yes, it is a deficiency. It is not an absence. That's the problem. It's a deficiency, and some RBCs are more deficient than others. So, yes, that is the problem. The quality of it, it's on a spectrum. It's on a spectrum. So, some RBCs have normal activity. Yeah, that's the issue. That's the issue that you get here with these type of patients. So yeah, it is a wild concept. Yeah, it is. Just keep that in mind. You have to wait 2 weeks at least. 2 weeks. You wait 2 more weeks after the hemolytic event, boom, now you're back to normal. Now you're back to abnormal, I should say. Not normal. Now you're back to abnormal. What the patient knows to be normal. Yes, 2 weeks after the hemolytic event, then the G6PD enzyme activity should reflect reality. It should reflect the abnormality. You got that? That's enough time. Yeah, that would be like enough time to make sickle cell trait. Well, sickle cell is supposed to protect you from malaria because I'll tell you what happens when it comes to malaria. You see this little cycle right here when it goes from merozoites to sporozoites. When it starts to no, it's not sorry, not sporozoites. When it goes into the cell and forms schizons, they're looking for RBCs, right? The malaria is looking for a nice home. Think about it like this. Yeah, malaria. Malaria is looking for a nice little home. And if it finds an RBC, it wants to inoculate this RBC and it wants to like basically spread and form into a schizon form inside that RBC. That's what it wants to do. But if it finds a sickled type of a cell that can sickle, yeah, it wants to find a nice little home. But if the home is, is faulty, it's not a good home, then it won't be able to enter and replicate in the way that it normally does. You see what I mean? Yeah. Yeah. Instead, it finds like some ghetto apartment, basically, where it's like, what's going on here? We can't make babies here. We can't, we can't live in this apartment. It's falling apart. There's no heat. There's no hot water here. Not good. Yeah, that's what happens. So yeah, that's why it's protective basically because They find the quality of RBCs to not be adequate enough for replication there, and you don't have the same rates of replication there. But okay, yes, good, 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 good. Hopefully that makes sense. All right, so getting back to this. Yeah, there's so many concepts, so many things everywhere that we just mentioned. I mentioned ketoconazole. I talked about mechanism of action. Um, yeah, we talked about warfarin. We talked about extrinsic pathway. We talked about malaria. Damn, wow. We talked about a lot. But okay, going back to this, guys, let me just ask you guys a couple more questions to make sure you guys remember the basics, okay? Remember the basics. We're going back to drills now. We might just end up doing like a whole week of drills, right? I'm going to recheck my schedule and everything. I know we have these 3 days coming up straight. I think 12 p.m. is a good schedule, maybe 11 a.m. as well. We'll see how we fix it, but let's come back to everything. So, all right, guys, I'm going to ask you guys treatment. Let's get the generalized treatment for a lot of different types of scenarios. If you have a patient who's experiencing angina, what is the regular type of treatment that we give these type of patients? What is like the standard of treatment? Do you guys remember a typical patient who has angina? Nitrates. Good, Miriam. That is true. I am with you there. I am with you there. Nitrate sounds great. Beta blockers as well is something that loves to be given. Now they do have like different types of strategies. They have different types of strategies you have to watch out for. All right, I'll tell you. Listen to this. If you have a patient, for example, who is who is experiencing angina, and they give the patient beta blockers, I've seen questions where they're asking you about the cardiac dynamics. They're going to ask you like, what is going on? So, like, what aspect of the heart are you modifying? The answer will always be a decrease in demand. So let me explain this to you and let me put it to you properly because I've seen some kind of confusion with a concept here. So I'm going to clear up a little concept here so we can move on when it comes to farm. Imagine this is the heart really quick. And let's take this little moment to grab the left ventricle. So let's just only grab the left ventricle here. Let me draw it like this. Show it off a little bit like this. Okay, this is the left ventricle, guys. Now, let's understand one thing. The heart itself, yes, it has its own irrigation, right? It has its own irrigation. Remember, we can see the irrigation is basically the coronary vessels. Yes, you have your RCA, you have your left coronary artery. Remember left coronary artery? You have your left circumflex. You have your left circumflex, which runs across. And then you also have your LAD, your left anterior descending artery. Okay, let's put it like that, right? So let's understand this dynamic really quick. One thing is based on blood that fills the chambers. Okay, that's one aspect of blood itself, of the circulatory system. One aspect of the circulatory system is the blood that fills the chambers. So I'm going to give it a pink color. Blood that fills the chambers. Another aspect of blood is the perfusion that's sent to the coronary vessels. Okay? So don't lose me. Let me know if you guys are losing me. All I'm telling you is that when it comes to blood in our system, some of the blood is responsible to fill up the chambers in order to have a proper preload. And this comes from the venous return. This is coming from the venous system. So venous return. Remember, you have your inferior, superior vena cava, all that venous return. That's what's going to basically be part of the preload system. But then you also have irrigation, which is coming from the arterial system. Okay? So now we're dividing the aspects of this. I told you that the blood that fills the chamber comes from venous return, from the venous system. And then I also said that the blood that is going to irrigate and give oxygen to the heart is coming from the arterial system, right? From the circulatory system. arterial. So that makes sense, right? Now, there was a crazy question. You guys probably aren't aware, but nitrates. What does nitrate actually do? What is the mechanism? Does it involve venous or does it involve the arterial system? Who knows? Right?
Venus.
Venous. Okay, Venus. We're getting a lot of Venus. Now, let me just tell you guys real quick. It does both. And let me explain to you guys. In higher dosages, it does have arterial dilation. It does also help you with a decrease in preload, in afterload, very, very slightly. But it does have majority action is going to be venous. So we were talking a little bit before where I told you about the idea of beta blockers. I said that beta blockers will decrease contractility. Contractility. So, what is it decreasing? Contractility is the decrease of the demand. The demand, right? You are decreasing the demand that you need to supply. So, if the patient has atherosclerosis, you have decreased the demand, therefore, the supply doesn't have to be so abundant. So, you can get away with not being able to supply a regular amount. You can supply a little less than regular and it's okay, right? That's the idea behind beta blockers. Now, nitrates, let me explain. A lot of people believe that nitrates mainly helps with perfusion. That's the false belief right here. Yeah, rate as well, Carolina, that is true. Rate as well. Rate is because it has the B1 activity of the pacemakers, but there's also non-pacemaker. But when it comes to nitrates, guys, a lot of people think, oh, this is definitely helping out with a lot of perfusion. But its number one cardiodynamic effect is that it will decrease the venous return. It'll basically make the heart have less contractility due to having less preload. Understand, there's something called the Frank-Starling mechanism. Don't know if I'm losing you guys, but think about this. There's something called the Frank-Starling mechanism. The more you expand the left ventricle, the harder it must contract. The more you expand it, it's like a balloon. If I blow a balloon up and then I let it go, it's going to go flying. If I just have a balloon, I blow it up a little bit and I let go, it's not really going to make much effect. So the heart tissue also has the same elastic effect here. They call that the Frank-Starling mechanism. So when you're giving a patient nitrates, what are you actually really doing? A lot of people believe that it has more to do with like actual perfusion, but what you're actually doing is decreasing the demand. So what you're actually doing here is, you see this pink area here? You're decreasing the preload, decreasing the venous return. Yes, therefore decreasing the demand, the contractility. Yes. Yes. Understand that. I'll repeat it again. Does anybody need me to repeat that? I'll repeat it again. I'll repeat that again because there's different aspects here. I'll show you the different aspects. So here, take a look at this. Beta blockers. Beta blockers decrease contractility. They decrease the myocardial oxygen demand. You do remember that you have different phases. Draw this little chart here. You guys can be familiar with this chart. Remember, the most important phase I always lock into is isovolumetric contraction. Because this is the phase where the left ventricle has poor perfusion and also just so happens to be the same phase where it consumes the maximum amount of oxygen. So this is where your angina happens. This is where you get chest pain. This is where you get MI. This is where you have ST elevations. This is depolarization of the ventricles. This is QRS. Guys, so try to understand cardio in this way, guys. Understand it through all perspectives, through the ECG, through the membrane physiology. Understand that this is the phase where you have your QRS. Remember, you have your plateau phase where you have your whole calcium in there. These are these type of phases. This is a systole phase. And remember, this threshold right here is set by the aorta. Aorta sets the threshold. Yes, angina happens here. So what can I do? I can decrease the myocardial demand here. I can decrease the demand. If I decrease the demand, then automatically, if I have an inadequate supply system because I have atherosclerosis is an inadequacy of irrigation. Like your perfusion is not available. You're not able to supply the oxygenation to a specific tissue due to the hardening or the accumulation of autoromas in those vessels. You can't allow the tissue with a high demand to actually receive oxygen. That's the issue with ischemia. So you'll notice one thing. Keep this in your mind. When it comes to nitrates, the major number one effect of nitrates will be to decrease the myocardial demand. And it decreases this indirectly. Indirectly. How does it do this? By decreasing the preload. So you decrease preload. This will lead to a decrease in stretching. Left ventricular stretching decreases. And that leads to decreased contractility. And then that basically leads to a decrease in demand. Look at that, how indirect it is. Beta blockers are more direct. Now, you guys understand that so far? Did that make sense? Say yes if it made sense. If no, let me know. Definitely. Good. Because this is common. So what am I trying to tackle here? I'm not just giving you yes. Good, Carolina. Good. Yes, but I'll tell you what is the difference. What is the difference? Beta blockers they tend to have dual effect. They tend to have effect on something else as well. Beta blockers dual effect is that it also deals with heart rate. It also messes around with your heart rate. Why? Because it also has that activity with pacemaker cells. Pacemaker. But overall, the number one activity will be to decrease contractility, therefore decreasing the demand. Okay? And nitrates decrease preload, decrease stretching, decrease contractility, decrease demand. Okay? That is different. All right. Now, I'm going to introduce you another one. Last one I'll introduce to you guys. So if I have an increased rate plus angina, beta blockers are good. Yes, they are good. Yeah. Basically, but here the main goal of achievement is to try to prevent the angina by decreasing the demand. So yeah, definitely. Now let's look at this. Calcium channel blockers. This one is different, guys. Remember, there's different types of calcium channel blockers. You have things like verapamil, amlodipine, different types, right? You have some that are more centralized to when it comes to like the cardiac system, while you have others that are more peripheral. So remember I told you guys about the arterial system. Arterial system. Major second messenger in the arterial system will be calcium. So you can actually decrease the afterload by giving calcium channel blockers. So here, the strategy of calcium channel blocker is to, now it depends on what type of calcium channel blocker. Let's see, how calcium channel causes vasospastic angina worse. No, it's It's a treatment. Yeah, it is the treatment for vasospastic events because it will decrease the amount of spasm that you can actually get by manipulating the second messenger system, by messing with the actual calcium that you have at an intracellular level. So that's the treatment. Yeah, that would be the treatment definitely. But I'll tell you this, guys. I'll tell you this. So far from the dynamics that we've spoken about so far, talked about how the preload could be manipulated by nitrates. Then we talked about how with beta blockers, you can actually decrease the contractility. How? You do this, yes, you do this by second messenger system. You guys remember beta 1. Beta 1 operates with GS. The major ion of GS, the major thing of GS is calcium. We said this before. We visited this before through a different angle. But yeah, this is what you'll end up seeing when it comes to the beta blockers. But if we take a closer look here at calcium channel blockers, you'll realize one thing. Calcium channel blocker basically causes, it inhibits the calcium influx in vascular smooth muscle. That's what would lead to vasodilation. That vasodilation will supply proper perfusion. So this one is different than the two that we've just mentioned, because we did say nitrates, and this is crazy, guys. You guys could quote me on this one because this is wild, but nitrates and higher dosages causes vasodilation at the level of the arterial system. Yes, it does. It does. I went down the rabbit hole. I think it was yesterday. I looked it up. It does. But it's not as significant enough to supply the demand, the high demand. Its actual function when it comes to basically being used as an agent for angina is the decrease in preload, a decrease in venous return. Okay? Good. We got that clear. I just want to clear that up. Now I'm talking to you about calcium channel blockers, which actually does inhibit calcium influx on vascular smooth muscle, leading to vasodilation. This one does supply perfusion. So what does it do? If I decrease the afterload, the threshold is now shorter. Remember, this is the isovolumetric phase, isovolumetric contraction. It has to respect a threshold. We can manipulate the threshold by manipulating the vascular resistance when it comes to the aorta. If I cause constriction, then the afterload increases. If I cause more of a vasodilation of the arterial system, then the afterload decreases. Does that make sense? Does that make sense? So this opens the door to a whole nother concept that you guys need to understand. This opens the door to a whole nother concept that you guys do need to understand. I'm going to make this very clear. You're not seeing this around the textbooks or anything, so keep this in mind. Pay attention. This was a very important concept here. Look at this. Left ventricle. In order for you to open up the aorta, the aortic valve, and basically get blood to the circulatory system, you are basically confined within the pressure of the aorta. What do I mean by that? So the number one rule, it's like the next space, the number one influencer when it comes to the left ventricular pressure will always be the aorta. So if I cause a constriction of the aorta, the left ventricle must increase the pressure in order to open up that valve. Does that make sense? I'll repeat. Left ventricles, or aorta. If I constrict the aorta, now I must have to produce a higher pressure, a higher systolic pressure in order to open up the aortic valve. That's what I mean. Right? You guys understand that? There's only one condition where this is not, there's one condition where this is not the case, where I can manipulate the aorta all I want and it doesn't matter. There's one condition. Yes, that is why we can give you hydralazine. Yes, that's why they give hydralazine, because here you can manipulate, definitely. And hydralazine also, you can give it pregnant women for hypertension because of the decrease in vascular resistance. But guys, aorta. If I cause constriction of the aorta, the left ventricle must produce higher pressure in order to open up that valve. So let me show you how this looks in a graph. Let's say here I have normal pressure. This is the isovolumetric contraction. It increases, and once it reaches the pressure, let's say of 120, it opens, let's say. Then you have your ejection phase, your rapid ejection phase, the slower ejection phase. Then you go to isovolumetric relaxation. This is diastole. So this here is diastole. And then you go to your filling phase, which is over here. So I'm marking right here systole versus diastole. And I'm just showing you that here the threshold was 120. Why was the threshold 120? Because of the aortic pressure. The aortic pressure set the threshold. It sets the threshold for systole. That's the point that I'm trying to make for you guys, is that it sets the threshold for systole. If I have some type of alpha 1 agonist, let's say I give norepinephrine, which is going to stimulate alpha 1, then guys, this 120 will go higher. I will now need, let's say, 150, let's say, in order to open up the aortic valve. Understand that. Understand this dynamics. There's only one condition. There's one scenario where this doesn't happen. Aortic stenosis. Aortic stenosis doesn't listen to the aorta. It can't. It's stenotic. It can't comply with the demand or with the lack of demand of the aorta. It's stuck. It has no power to, let's say, to follow the lead of the aorta. So stenosis is the only one that doesn't really match what I'm saying right now. Meaning I can have a strong vasoconstriction or I can have a vasodilation. The aortic valve is not opening up like it should. So it doesn't matter. Okay, keep that in mind. Now, that's the left ventricle. Look, guys, I'm going to make a big emphasis on this. That's the left ventricle. And if you guys did not understand, just let me know, type it in there, and I'll repeat it in a nicer way, and I'll repeat it in a simplified way. But that's the left ventricle. Left ventricle is basically a slave to the aorta. If the aorta wants to increase the constriction, now the left ventricle needs to work harder. Now, right ventricle. Right ventricle. Who does the right ventricle listen to? Who is the right ventricle?
Pulmonary vasculature.
Yes. The pulmonary vascular system. Yes. And I'm going to keep it vague. I'm not going to say the pulmonary artery. I'm not going to say the pulmonary vein. I'm not going to say the lungs itself. Why? I'll tell you why. Because so many things can go wrong with the lungs that we can't just blame one anatomical area. And I'll tell you what happens. If the patient have a pneumothorax, for example, patient has a pneumothorax that's affecting, let's say, that pleural system, that intrapleural system near the alveolar space. The pressure goes very high. Pressure goes so high that it can attend to pneumothorax that you even start to deviate the trachea. But I digress. The pressure goes very high, let's say with a pneumothorax, any type of pneumothorax. Now the right ventricle, let's say the systole, let's not just say, I believe the systolic pressure of the right ventricle is about 30 systolic pressure. Now, let's say the pulmonary system has increased in pressure. The right ventricle must now comply to that higher level of pressure. So instead of having a systole of 30, you'll notice that it'll have to push 50 or 45 or even higher in order to get the blood from the right ventricle to the pulmonary vascular system. Understand that. That is such a key concept. I can't tell you how many questions just based on this. Just based on this aspect. Why? Because this is not only pneumothorax. This is pulmonary edema. This is like pneumonias. This is like consolidations. These are tumor masses. This is PA PAH, I think it was pulmonary arterial hypertension. This is so many different types of conditions where you're forcing the right ventricle to work harder. Okay. Tetralogy does have an increase in pulmonary arterial pressure. That's also due to VSD, I should say. VSD is another thing that causes this type of issues as well. ASD, I remember as well. ASD has these kind of problems. In ASD, you're having increase in volume. I remember it's fixed splitting, so you're going to get volume regardless. Like if you breathe in, normally you get higher amount of volume from the right side. Here it doesn't matter. With an ASD, you breathe in, breathe out. You're still getting the extra volume. Either you're getting it from your um, right side by breathing in, or you're getting it from the left side due to the shunt. If you guys don't understand that, it's okay. That's just me explaining to you why there's a wide fixed type of splitting. Fixed meaning that you cannot modify it with exhalation or inhalation, is going to fall the same level. A lot of people have problems understanding that. I could explain it. But before I jump into that, let me just tell you, yes, here you have pulmonary hypertension, let's say. Your right ventricle is going to be screwed. Why is the right ventricle screwed up more than the left ventricle when it comes to this scenario? The left ventricle is muscular. It has a great amount of muscle tissue. It manages higher levels of pressure. The right ventricle is not so much the case, which means that it has to depend more on volume. Cor pulmonale, anything that causes, cor pulmonale can lead to this type of scenarios as well. Yeah, definitely. But listen to what I'm saying here. It it relies more on volume than anything. So really quick, as soon as you start to see an increase of high demand on the right ventricles, you will also start to notice that the right ventricles will activate RAS system because you're not getting enough blood here. That means you're not getting enough blood to the left side. You're not getting enough blood to the left side. You're not putting out enough blood to the circulatory system. You're not putting out enough blood to the circulatory system. Then you are failing to give 20 to 25% of cardiac output to the renal system, which activates RAS. That's a whole other conversation. I hope you guys understand cardio to the point where you guys could connect everything. Because once you start to connect things, it turns into a lot of fun, I would say. I actually have fun studying cardio because it all makes sense. It all makes sense. Like, this is why a patient can have JVD. This is why you start to see a jugular venous distension with someone who has, let's say, pneumothorax. It's like, why in the world is he having a JVD with pneumothorax? Well, his right ventricles they need help to get blood into the pulmonary system. They're not a muscular system themselves. They're causing increase in preload. And if you increase your preload, your venous return on the right side, right ventricles, the right atrium will now have to also increase volume to get its contents into the right ventricle. I do not want to confuse anybody. I hope everybody's understanding more or less. There's concepts to this. So if you're new here, let's say not usually in the drills or taking classes, it's all about concepts. Like there's concepts that are like, let's say, more basic, like the concept of pressure going from high to low. All pressure always goes from high to low. That's how we are as well mentally. If something is more difficult or has more pressure, we tend to, on autopilot, go the opposite other route. So just know that. Just know that if the right ventricular pressure increases, guess who will have to increase the pressure in order to get blood into it? The right atrium. And so forth. And this can back up. When it backs up, it causes JVD. That's how I know that the right heart is undergoing a higher demand, higher stress. And if it backs up, let's say, let's continue the scenario. Let's continue painting this picture. Let's say there's a high level of pulmonary pressure. First, before anything, what if the right ventricles cannot get blood into the pulmonary system in the first place. Let's say you just can't. Let's say the pressure that has been produced in the lungs are, this is giving you a crazy scenario. Let's say it's 140. And the right ventricle is like, hold on. I can give you 50. I can't give you 140. Obstructive shock. There you go. Yes, that is obstructive shock. Now, Marianne, I would ask you, how is the pulmonary capillary wedge pressure in obstructive shock? Low, low, because you're not able to get blood into the left atrium. It's not going there. Good. You understand that. That's good. Perfect. Awesome. It's okay. Now let's go back into telling you the struggles of the right ventricles. If the right ventricle has to achieve a higher pressure, it's going to use volume. We said that. The volume that the right atrium would have to use would also increase. Yes, it would have to increase because now the right atrium has to have that systole where it gets that little bit of blood that it has into the right ventricles. Therefore, it needs to increase with more volume. So then this backs up to the jugular system. Jugular. Good. Now this backs up where? What's the next area? The next anatomical area that undergoes this flooding. Let's just call it a flood. That's what it is. Hepatic system. Yes, the hepatic system. And this creates something called portal hypertension. Portal hypertension, yes. This can cause portal hypertension. Now, the portal hypertension gets really, really bad. It can lead to, because pressure travels from high to low, I'm going to repeat, it goes from high to low. It starts to accumulate in the peritoneal area, causing ascites. Yes, ascites. Ascites, correct. And this particular type of ascites has a serum albumin ascites gradient higher than 1.1. Oh, albumin gradient, sorry. Serum albumin ascites gradient, when you subtract it, is going to be greater than 1.1. Okay? Yeah, well, I'll tell you, you can have a portal hypertension with ascites. The moment that you start to see jaundice, the moment that you start to see varices, the paraumbilical, the esophageal varices, the moment you start to see these kind of things, that's more related to cirrhosis. So when you start to have, let's say, cirrhosis reminds me a lot of a chronic pancreatitis, where these cells start to wither away rather than causing a loud type of death where they're dying and you're having high liver enzymes or very high pancreatic enzyme. Like they slowly like wither away. And then you have a cirrhotic patient and then the functionality goes down. That's more of what you see in the level of cirrhosis. Do not confuse that with acute liver failure. Acute liver failure is different. Acute liver failure is more like acute pancreatitis in the sense that the death is very loud. The actual criteria, I don't know if you guys remember, with acute liver failure, which definitely has a problem with functionality. The criteria is that you have an INR increase, it was higher than 1.5. So for acute liver failure, this is different, guys. I'm telling you that this is not acute liver failure. I'm telling you that this can lead to more of a cirrhotic type of complication, something that will show your liver withering away, losing functionality gradually to the point where you have jaundice, to the point where you have, you can get gynecomastia because you lose your ability to metabolize sex hormones properly. But what I'm saying here, acute liver failure is different. Do not confuse the two. It's this concept to me in my brain is filed in the same shelf as acute pancreatitis comparison to chronic pancreatitis. It's like acute liver failure comparison to cirrhosis. You gradually lose functionality on both scenarios. Liver enzymes become more blunted rather than increase very high. So in acute pancreatitis, you have very high level of lipase and amylase. In acute liver failure, you have the liver enzymes in the thousands. And then for your final criteria to basically rule this in as a acute liver failure, final criteria is that they need to have evidence of damage of functionality when it comes to ammonia. You have to have one of the symptoms. You have to have confusion, asterisks, something that lets you know that the urea cycle is non-functional. That's the final criteria of acute liver failure, guys. So if you get that, if you get like, let's say, hepatic encephalopathy symptoms like asterisks when the patient starts going like this to his hands, that'll give you your acute liver failure. Encephalopathy. All right, but anyways. Yeah, we're jumping all over the place. Today we're jumping all over the place. Not tomorrow. I'll announce the next topic for tomorrow. But let me just tell you guys. So okay, going back to this, I'm just gonna recap what we just said. Just gonna recap so we don't get lost, so we're not just throwing off a bunch of information randomly. So here comes a recap to organize this properly. We talked about drugs of cardio, and it's no longer just important to know what drugs are you going to use. Now you have to understand the strategy of why they're using this drug. When it comes to angina, you have an issue with supply and demand. You have either a high demand and your supply is not reaching that level. So let's say this is your high demand, but your supply is not getting there. What does that mean? Your tissue demands more oxygen in order to realize its contractility, but the supply is inadequate. Okay? Why is the supply inadequate? I mean, the blood is there, it's just that you have atherosclerosis. So you're not able to get the blood into the tissue. Okay. So this is what typically happens in angina. This is one way of having angina. I'm going to compare another way as well. I'm going to tell you another way as well. There's another way where you have, let's say, increase in here, the supply is low because of the atherosclerosis. Let's be very clear. So let me be very clear here. The demand is high. The atherosclerosis is causing a decrease in supply. All right. There is a type of angina, and let's pay attention here, guys. Here comes another concept. There's a type of angina where you don't really have atherosclerosis. This is a new world, guys. This is a new world, so pay attention to this one. This is a weird one. A patient who has aortic stenosis, they can have normal vessels, meaning they do not have atherosclerosis. They're just operating at a super, super high demand. Their supply is not low. Their supply is normal, meaning that their circulatory system has proper dynamics that can actually fuel that system properly. But just the demand gets so out of hand, so exaggerated, that it starts to cause angina. Have you guys heard of this before? Let me know if you guys have heard of this concept before. This is a non-atherosclerotic type of angina. Okay, so watch out, pay attention to this one. Normally, atherosclerosis is what leads to angina because you're unable to have proper perfusion to the tissue due to the accumulation of autoromas. All right, that's what normally happens. That's what we normally see. That's sort of the dynamics. But there's also an alternative where you do not have atherosclerosis. Instead, you have aortic stenosis that's very exaggerated, and it causes the heart to demand so much oxygen. And you can supply it, but the demand just gets out of control. It gets to the point where it's out of control. It gets to the point where the demand is so high that now your patient is hitting angina. Okay? How overcome the pressure gradient heart had to work hard. I don't understand your question 100%. I'll just tell you that, okay, are you explaining it? Because yes, there's a pressure gradient. that is created when you have aortic stenosis, and your heart has to work harder. It has a higher demand. Yes, that is what happens. So that on its own creates angina. So I'm just giving you that extra little concept on the side, guys. Keep that in mind. But what we were talking about here with an decrease in supply due to atherosclerosis, um, and this is basically, we talked about medications that try to fix this, like beta blockers, which tries to decrease the demand, right? Decrease demand. Then we also talked about nitrates. Do not fall for the tricks. People think nitrates is more of a perfusion thing. Nitrates decrease demand by decreasing the preload. Okay, do not fall for the tricks. And then when we talk about calcium channel blocker, it's more on the supply side. Well, it could differ. If it's calcium channel blockers that have affinity, like verapamil, that has more like affinity to the heart tissues itself, that could decrease contractility. Yes, yes, that can work on both sides. Good. We understand that. We understand that. We're good. Those are the three drugs you guys would definitely need to know. Definitely need to understand how they work. What are the dynamics? There's different ways of asking you questions about this. I've seen it all around. It's on step 1, step 2. It's everywhere, even step 3. They'll be like, what were the question is like, hey, what was the they're trying to achieve? Oh, decrease in preload, decrease in that. So understand that. All right, good, good, good. That's what we spent earlier. We spent some time talking about that. We were able to understand all those dynamics. I mentioned the threshold. I mentioned this very important concept here about demand, about how the right ventricle is basically a slave of the pulmonary system when it comes to the vascular system, because if it increases pressure, the right ventricle needs to comply. Same thing goes with the left ventricle. It follows the leader, aorta. Aorta is constricted, higher threshold. It needs to produce more than 150 in order to open up the valve. Good, 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 perfect. And then we talked about portal hypertension, how this can back up, how this backs up to the liver system. Coarctation of the aorta below and above the clear. I don't remember exactly. Yeah, coarctation is a bit confusing. I'll tell you why. Because if you have a cyanotic type of issue, like let's say you're born with a cyanotic type of heart problem, they'll tell you to keep the coarctation in order to have until the surgery can get done, until corrective surgery gets done. Do you remember what drug you're supposed to give in that sense in order to try to keep these, to try to keep I'm saying coarctation. I'm thinking I'm thinking PDA, patent ductus arteriosus. I'm thinking PDA. I'm thinking PDA. Yeah, sorry. Coarctation of the aorta. Yeah, you're thinking something else. I'm thinking PDA completely. Yeah, when it comes to coarctation, yeah, that's like that narrowing that you can have. You can have the narrowing in different areas. Yes, definitely, you can have this extensive type of narrowing, and that can cause a discrepancy within the blood pressure. That's the problem. So preductal is the infantile type of issue that you tend to see, right? Preductal. This is what affects more of like the infants. Don't know if you guys remember. Yeah, the idea of indomethacin to close it, the idea of alprostadil to leave it open. That was for a PDA. That was a patent ductus arteriosus. That's different. This one here, this one no, this one is like basically a narrowing, and that narrowing causes a higher vascular pressure before the narrowing, leads to like rib notching. I don't know if you guys remember that. It can lead to rib notching, like intercostal type of enlargement, like the vessels in the intercostal area get really big. Definitely. And yeah, that's definitely seen in that sense. But okay, let's continue. Let's continue. Uh yeah, let's see. We already did like an hour and a half. Let me sprinkle in a question. Let's see if we can get some little more questions in here. Hopefully some cardio stuff. Oh, okay, hold on. All right, I think I see a nice cardio question talking about the dynamics of blood. Let's look at this one here. All right. Should I read it or not? I feel like you guys like it when I don't read it. Let's use teamwork. Let's get this. Let's go. Doppler ultrasound interrogation of the fistula will most likely reveal which of the following blood flow patterns. A 32-year-old man evaluated in the emergency department due to fever, night sweats, chills over the last several days. Oof, not good. Very non-specific. I'm thinking so many things. My brain is just going crazy. The patient has been using intravenous drugs recently, and he is stressed out, and he has otherwise been in good health with no medical problems. Temperature is 38, blood pressure is 120, pulse is 105 and regular. Okay, so this is so far there's been nothing here, but he just says here further evaluation reveals aortic valve endocarditis with an intracardiac abscess, small fistula formation between the aortic and the right ventricle. Okay. All right. Doppler ultrasound interrogation. The fistula will most likely reveal blood flow, which are the patterns. This is you guys should get this. Remember, I told you guys a big important rule. I mentioned one thing. Aorta to right ventricle. It says here the abscess formation between the aortic root and the right ventricle. So just imagine this. Imagine you have here aortic root, but it is connected somehow to the right ventricle. This and this are connected. Where will the blood flow? You guys remember high to low. It's that easy, guys. That's how easy the concepts are. That's how easy the concepts are. What do you guys think? Let me go get one second. Let me go get a coffee I left in the fridge. Write the answer down if you guys think you know it. Make sure you write it down. Use teamwork. Give it some thought. I carried away. This got frozen, but we're good. All right. I see a lot of B's. I see a lot of B's. Does everybody think it's B? What do we think? I see somebody put A. Bluina put A. Um, aortic root would have a higher pressure than right ventricle, is what you're asking. Would the aortic root have higher pressure? You're asking. Well, think about this. So hold on. They did put systole, diastole. Give it some thought. Let's see. Carolina said A. Mira said A. Kumar says B. Yes, it does. Yes, Carolina, it does. Okay, guys, definitely let's talk about this. Definitely this needs to be talked about because yes, Carolina, you are right. You are right. I'm with you there 100%. Aortic root is at high pressure in both systole and diastole. Especially on systole though. Like on systole it'll be exaggerated like the difference. But it's still remember if you guys remember the systolic pressure of the right ventricle was about 30. Like the diastolic was extremely low. I think it was even lower than 15. It was super low. So yeah, let's get the actual pressures. What do you guys say? Let's see if we can look at for the actual pressures. Um all right, I found it. I found it. Yeah, UWorld has it. UWorld has it, which is awesome. So look at the pressures here on UWorld. The first number is going to be like the systole. You're seeing the systole in the first number. So I have seen it reach 30 as normal. Here they have it as 25. Let's say 25. So take a look at what's going on here. The aorta itself, we know the both pressures, systolic and diastolic, because like I told you, it sets the threshold. It's at 120, 120. And the diastolic is going to be like at 80. So look at this, the right ventricle, 25 and 2. That's extremely low. Okay, I think I see what they did. I think they went with the lower spectrum. I'm gonna look for another image that also has the pressures because I've seen different types of pressures. What they did is that some of the pressures are like, let's say they say 2 to 5. They just went with the lower number. Uh, let's see. Mm. Yeah. All right, it's more or less the same. Yeah, this is what I was looking at before. This is like from Brown University. Let me just see. Let me show you. 1530 to 0 to 8 for diastolic. You see how it changes? So you have your systolic 100 to 40, 3 to 12. Like the numbers are not like concrete. Like there could always be a little bit of variation there between them. Um, but okay, what I'm trying to tell you here is that as you can see here in the aorta is a major difference in the sense of right ventricles. So yes, this is going to be a continuous type of change. And this is going to be both systole and diastole because it's higher. And remember what we told you, right? Remember what I said. This comes into the first concept that I mentioned. The concept that I mentioned was that pressure always goes from high pressure to low pressure. High to low, always. That's just how it is. That's how life is. That's how mentally we are as well, spiritually. We always choose the lower pressure route. We avoid problems and we choose the lower pressure route. That's the idea. Does that make sense? Are we good? Everybody's good. Everybody knows that? Everybody's good? This was a nice question here. I like the idea because it tests one of our most, I would say, primitive type of concept, our most basic concept. That's just mentioning high to low. Okay, high to low. All right, let's continue then. Let's continue with the next question. Hopefully, it's a cardiac dynamic type of question thing here. Oof, let's see. Oh, nice. Valves. I love valves. I used to hate valves. You guys know that? I used to have so many problems with valves and all the trick questions that they did. Now it's like you know the clues, you know your valves, you're good. You know what's important too about knowing your valves is what's considered um drastic information and what's considered like let's say not as important. For example, the intensity of the murmurs. You can have like they can say, oh, 2 out of 6 systolic murmur on a newborn. Guys, if you guys ever see this, this is benign. This is okay. There's no issues here. This is normal. This is good. Newborn has this, no problems. Let's say, then you have a fistula from the arterial to the venous. It's the same. Yes, same concept because the arterial pressure manages higher pressures. Venuses measure lower. AVMs, atrial venous malformation. It causes a continuous type of sound. If you ever hear it, you can put a stethoscope on a patient who does dialysis, and if they have one of those like those type of AVMs, those type of fistulas, you listen to it and it sounds like it keeps going. It's pretty cool. You can feel it too. You can feel the vibration on it. So, guys, really quick, let me just tell you when it comes to murmurs, this here's benign. Do not fall for this trick. What makes it not benign? What makes it dangerous? If I put 4 little letters right here. So, you see this description right here is benign. 2 out of 6 systolic murmur, newborn, benign. How do I make this a dangerous statement? All I have to do is put this next to it. Hollow systolic. All right. Let's see, guys. Let me erase this. Let's look at this question and let's dive into it. Let's see. So, which of the following is the most likely? Oh, sorry. Would would most likely be seen on echo. Okay, guys, let me just tell you on the way as well. Echo is very important. It's an important tool because you can use this to try to see the functionality of the heart as well. Not only to view the anatomical um, evolution of the valves, like any kind of valvulopathy, but you can use this for the cardiac um, the dynamics when it comes to functionality, the ejection fraction. 14-year-old girl is brought to the office for a routine physical examination. The patient will be starting her freshman year of school. That's awesome. She plays the clarinet in school band and does not play any sports. Okay. This is pointless information so far, but let's see. The patient is not sexually active and does not use alcohol or illicit drugs. Height is in the fifth percentile. That's why somebody said Turner's. Now I see why, right? Weight is in the 25th percentile. Okay. Temperature 36. Blood pressure is 120 over 80. Pulse is 88, and respirations are 16. Okay, so physical examination shows short, thick neck, broad chest, shortened fourth metacarpal bilaterally. A murmur is heard on auscultation. What will be seen on the echo? Everyone is saying B. I mean, come on. Come on. What happened? I feel like I clicked on the easiest questions. The answer here is B. Yes, the answer 100% is B. Does that make sense? Hold up, hold up. Let me mute. Quick. I got it. One second, 1 second. There it goes. Good. All right, we're good. All right. Yes, that was easy. That was easy. I don't know what in the world is going on with this question. Definitely, I feel like I clicked on the easiest ones, but okay. Let me just ask you guys then, really quick, since we're running down this list. ASD. Remember, guys, I told you guys ASD, fixed splitting, right? Fixed splitting. That makes sense. ASD is typically seen in Down syndrome. Down syndrome is correct. Yes, Down syndrome. Good. Bicuspid aortic valve. That was the answer here. Yes, bicuspid aortic valve. Now, let me just tell you something as well. Let me tell you guys something. This is a high yield. Bicuspid aortic valve. Listen up to this. Listen up to this. This is important. In a bicuspid aortic valve, you are more prone to have infective endocarditis. Yes. Bicuspid aortic valve. If you do undergo any type of attack on this valve, it is not able to withstand the normal attack. If you have any kind of fibrin deposits, let's say IV drug use or anything of that sense where you're having problems with any kind of valve, any kind of you'll be more prone to have an infective endocarditis. Now, here comes another important concept. I knew there was one more important concept we have to give before we finish. This is a good one, so listen up for this one. Listen up for this one. Check this out. Let's say this is the left heart, and this is, sorry, no, this is the right heart. Whoa. And this is the left. Okay? Pay attention on this one. At least this last one, pay attention. We're going to end this one here. This is the last little concept here. Keep in your mind, okay? Keep this in your mind. Let's say a patient, like in a question like this, has a bicuspid aortic valve. Bicuspid aortic valve increases the risk of infective endocarditis. If you are put at risk for infective endocarditis, let's say, and you undergo an issue with infective endocarditis, can you guys remember the symptoms? What are like the symptomology? Like what kind of issues does a patient have with an infective endocarditis? What should I expect to see? Does anybody know? Can anybody tell me? Infective endocarditis, fever. Okay. All right. Let's go. So far, so good. Fever. What else? Okay. I mean, more systemic. We're looking for something more systemic. Yeah, because definitely think about it. If you have let's say, it's okay. I'll tell you. You remember all the crazy stuff, the Osler nodes, the Roth spots, Osler nodes. You have these nodes that are very painful. You have splinter hemorrhages. Remember, you also have palms and soles. You can get these little Janeway lesions. You guys know that, right? I'm just here reminding you of all the craziness that could come with that, right? Does that make sense? That makes sense. That's nice. All right, good. If not, look that over in the first aid. Definitely, it is worth going through just to know all like there's a Duke's criteria that you have there, the minor and major, and you can get all that craziness. Okay, Jane criteria. Yeah, Jane, I remember as well. I remember the idea. Yeah, but point is this. Point is this. Pay attention here. Check this craziness out. The reason why you get all of this is because when you form a infective endocarditis, right? You end up making septic emboli. You end up having the dissemination of septic emboli. That septic emboli can cause an array of different types of complications, even hemorrhages at the level of the eye. Like, you can cause so many types of complications there with an infective endocarditis, right? Step two, people, just remember you take two blood samples. You take blood samples from different areas, and then you give empiric antibiotics, right? But you have to do the sampling first and before you do the antibiotics. Remember that. My point is this: the reason you're getting all of this crazy type of septic emboli is because of the endocarditis. If, for example, you have a patient who's an IV drug user and ends up having fibrin deposition on one of these valves, that also increases the risk of infective endocarditis. If you end up having infective endocarditis in the right side of the heart, you might not see all those crazy symptoms. The reason why is because the septic emboli that's being dislodged is going where? Where is the septic emboli going to? The pulmonary system. The pulmonary system. And if it's going to the pulmonary system, guess what you're more prone to have? Rather than all those Osler nodes and Roth spots and all that, instead, you'll see a patient with a pulmonary embolism. Pulmonary embolism. Okay, endocarditis. So look at how crazy this is. Infective, I'm telling you guys right now, infective endocarditis of the right side of the heart leads to pulmonary embolism. Does that make sense? Good, good, good. A lot of people forget this. They're thinking that they miss the diagnosis because they're expecting to see all the craziness of the Osler nodes and the Roth spots and the Janeway lesions and all that. You might not see that because everything is getting stuck in the pulmonary system instead of getting stuck at the circulatory system. Okay? Remember that. Remember that. If the right side is affected, you're going to see pulmonary embolism. Okay? Very important. Now, I should also include, what would be the treatment? IV drug user who has this kind of complication, what should I give? What kind of antibiotic would be good? What must I include? Which antibiotic? Give it a guess. If you guys don't know, you can give it a guess. Your score's not going to go down by guessing. Vanco is perfect. Vanco is perfect. Vanco is great. Yes, because chances are this is going to be a staph type of infection if it's an IV drug user, right? You guys know that. You guys know that. That's great. That's great. That's good. So you guys are seeing this concept right here. Learn this concept. Very good concept, actually. Pulmonary embolism. Now I'll ask you guys another little trick question here. The PCO2. How would the PCO2 be with a patient with pulmonary embolism? Should it be high, low? What's up there? What's going on? The answer is, drum roll, drum roll. The answer is, it will be low. It will be low. It will increase your respiratory rate. CO2 is a lot more volatile. It does actually leave. It does actually leave. Yes, it does leave. A lot of people get confused with that because a lot of the ventilation, perfusion, problems that you have with pulmonary embolism leads students to think that you are going to retain the amount of CO2, but that is not the case. You're able to release the CO2. Okay? You're able to release the CO2. Yes, CO2 is much more volatile. It's able to leave, is able to be picked up. Gas exchange is unfair. It's unfair. It's not giving you the profit of oxygen, but it's taking away the CO2. It is. Okay? Keep that in mind. And yes, it causes something called pleuritic chest pain. Pulmonary embolism has pleuritic chest pain. What's another thing that has pleuritic chest pain? Who can tell me? Tell me one more thing with pleuritic chest pain. My spider senses goes off when I read a question. It says pulmonary. It says pleuritic chest pain. Pericarditis is a great one. Although pulmonary effusion, you can, but there's levels to it. Like pulmonary, let's say effusion, it has levels to it. Like there's a severity to it. But in pericarditis, you're gonna get it, right? Pericarditis, that's the typical pleuritic chest pain. What in the world is pleuritic chest pain? That means that when I breathe in to the maximum, it hurts. When I breathe out to the maximum, it hurts. So I'm within a range of my breathing. I stay within a range in order to avoid pleuritic chest pain. That's the difference. Pleuritic chest pain is a type of pain that you keep within a certain amount of pressure, because if you increase your pressure too much, now you feel pain. You typically see this, yes, pericarditis. There's other conditions as well, but it's classically big clue for pericarditis, big clue for pulmonary embolism. Keep that in mind, okay? Keep that in mind. Now, bicuspid aortic valve, I mentioned to you the increased risk of endocarditis, but in all honesty, yes, it also causes aortic stenosis most commonly. It can also cause aortic regurg as well. And it's kind of crazy because why is it most commonly aortic stenosis? I'll tell you why. If a patient has a bicuspid aortic valve, let's say it's bicuspid, and the patient gets older, you have an earlier onset of aortic stenosis. Yes, and since a lot of these patients make it to a certain age, then yeah, of course, this is why it's the most common. But what I've seen from Turner's is that the bicuspid aortic valve has been related to aortic regurg. So keep this in mind. I've seen this in Turner's. Saw it in MBME question with Turner. Don't remember which one. But it was talking about cardiac dynamics that are found in congenital disorders. That's high yield as well. We'll drill on that next time. We can jump into that. Yeah, definitely. With Turner's, aortic regurg, a lot of that is seen with just a male adult. Male adult, they tend to have aortic stenosis. All male adults tend to get aortic stenosis at the age of about 70, 60, but we can get it earlier onset if you have bicuspid aortic valve. That's the problem. And why does it happen? It happens because of an excessive amount of calcification. We get calcification of the valves. Yeah, they get it earlier onset when it comes to patients who have bicuspid. That's the idea there. And then the third one that we mentioned, we're going to include it here in this little list, just so you guys do not forget. The third one that was mentioned, the third one was increased risk of infective endocarditis. And then I gave you guys that concept, that crazy concept, that if the source of the endocarditis, if it's all coming from the right side, right? If it's coming like more from the right side, you do have septic emboli, but this septic emboli starts to lodge itself off to the pulmonary system, leading to a pulmonary embolism, rather than the systemic type of patterns that you see with patients with ulcer node and Janeway lesions and Roth spots and all that craziness. Okay. So yes, guys, yes. This is high yield. Basically going through all this information. This question was way too easy, guys. I had to include some kind of concepts. Let me just tell you guys, mitral valve prolapse is the most common valve issue. But good thing is that it's not a problem. It's not a problem. It doesn't really cause a problem. It's safe. It is benign. It is benign. I don't know if you guys remember that, but it tends to be benign. Mitral valve prolapse. Mitral valve prolapse and HOCM are the two types of like conditions where if you increase preload, it gets better. It gets better. This one has that mid systolic click. Do not confuse that with the opening snap. The opening snap. That's different. So remember, mitral stenosis has the snap. Mitral regurg has radiation. But now, guys, let me be 100% clear. This is fine what I'm telling you guys right now for step one. This sounds awesome also for step two as well. It sounds nice. But there's questions where there's a radiation with a mitral stenosis. So a lot of the details and clues that we learn, you'll learn in step two. Some details are stronger than others. Yeah. Yeah. Axillary, yes. You'll learn that some details are stronger than other details, guys, and they use this to trick you. They use this to trick you in questions. So luckily, I've been through that war. I've been through the battlefield. I have basically. I understand when they're trying to give me some things that are just trying to cloud my judgment when it comes to clues, because there's some clues that matter more than other clues. And that's something that we will have to definitely work on. Things I can tell you about. Things I can tell you like, okay, pay attention to this, don't pay attention to that. Like the intensity of a systolic murmur. Yeah, be careful. Be careful with that. There's benign murmurs that they're going to describe as systolic for infants, for newborn. Like the 2 out of 6 systolic murmur, mid systolic 2 out of 6 murmur. That's benign. If it's hollow systolic, it's not benign. That you have to investigate. So there's a lot of little things like that, guys. A lot of little things like that, and we're back with the drills. Good news is we're back. We're back. Going to try to keep it consistent today. We did a longer type of episode, definitely like more than 2. We did about 2 hours here, no breaks at all, just straight up 2 hours. That coffee actually did good. Colombian coffee is legit. I gotta say, they added these Colombian shots in it, so good. So definitely, I'll catch you guys tomorrow. I will catch you guys tomorrow. 12 p.m. is good. Or no, let's see. Let's see. What time is it right now? I wonder. What time is it right now? Okay. My computer's crazy because my computer gives me different time in different place. Um, yes, we'll see. We'll definitely as for a camp, guys, I'm thinking next week I'm starting off the camp. Next week I'm starting off the camp endocrine. I'm going to go hard with a lot of subjects, excluding farm. Officially next week, we start off next week with a camp. Sign up is today. You guys can sign up. Today is official. You guys can sign up. Camp is starting on Monday. It'll be a camp based on endocrine, on pharmacology, and pharmacology. We're going to go to different subjects on farm, and I'll definitely talk to you about all the tricks. I'm trying to stay focused, also mentioning all the outliers, all the tricks like we did today. There's a lot of little tricks you guys have to try to get, so you guys don't have to get the questions wrong several times in order to understand these things. You guys could just understand it naturally. Get this down naturally. You don't have to memorize things. Just understand these concepts. Guys, know the concepts. I would tell you in the chat. I'll announce it. So all those that are part of the group, you guys will know. I have to look it over. I do have to look it over. There's a couple of subjects I want to do. I'll announce it on the chat, but definitely tomorrow, I would say I'm on Central Time. So 11 a.m. is good for me. 11 a.m. Central Time. We'll start off. Definitely, guys. Definitely, we're focused 100%. Thank you guys for joining me today. We're back. I'm going to upload this This drill had so many subjects. I don't even know how to title this drill. I mean, come on, we went everywhere. We did everything. 11 a.m. Central is 12 p.m. Eastern. Yes. Yes, yes. Hopefully that's a good time for you guys. Hopefully that is a good time. All right. Perfect, perfect, perfect. Thank you, everyone. Thank you. I will be uploading this. You guys can all catch this video. Thank you, everybody. This video will be available for everyone, but moving forward, definitely putting them on the tiers. If you're not part of the Patreon, join the Patreon. I'm promising to you a whole bunch of class, especially next month, more than 15 classes, free classes as well, guys. So don't worry, don't worry. Got you guys covered. All right. Thank you, everyone. Thank you for participating, collaborating, helping me out. Definitely. Thank you for being a member. And I'll catch you guys tomorrow. Yeah, we're going to continue. We're going to continue this tomorrow. It doesn't stop. You have to get all these concepts down. Okay. So thank you guys and catch you guys tomorrow. Take care. Take care. If anything, write to me on WhatsApp.